Next is about the peptic ulcers, where both gastric as well as duodenal. Incident-wise, the duodenal ulcers have become, gastric ulcers have become less frequent. Even duodenal ulcers also have become less frequent now these days, whereas the other conditions like gastritis and atrophy, they are more frequent now. Whereas a few years earlier, like some 20 or 30 years earlier, peptic ulcers were more prevalent. The reasons, of course, not known. But anyway, if the patient has developed a pain which is related to the food and a less frequent vomiting, then it's a suggestive of duodenal ulcer. Whereas the pain relationship with the food with more frequent vomiting is usually due to the gastric ulcer. When you do the endoscopy can make out the diagnosis easily, differentiation easily between a peptic ulcer and the gastritis-like condition. The ulcers, in case of the gastric ulcers, would be usually more than 2 centimeters wider, and they also are deeper. Even the submucosal plane also may be seen. Many times these could be suggestive of neoplastic lesions too. So gastric ulcers are more frequently converting into the neoplastic lesions, and hence the ulcer biopsy would be necessary. Whereas duodenal ulcers, they would be having a similar issue, the deeper one, but chances of malignancy are lesser. You will see some slough tissue also in case of the ulcers there. So that's about this current this presentation of the peptic ulcers as such. And the Sushruta has described this in the context of the Parinamashula and Sri Nidane Prakrita Vayu Sanhitasla Kapitte Samavritya Shulakari Bhavet Bale Bhukte Jiriyate Shulam Treva Pranajam Tasya Lakshanam Apyata Samasena Bhiyate Chardi Hrilasa Samoham Salparuku Dirgha Santati Katatiktopasantam Chatati Nyam Kapatnakam. If there is a relationship with the food and the spicy food would be reducing the symptoms, that's a typical of the peptic ulcers. Now, peptic ulcers also may be accompanied with the atrophic changes and H. pylori induced ulcers. H. pylori induced ulcers are very characteristically having lesser edema around the area, and there could be atrophy also. H. pylori, invention of H. pylori is one of the major breakthrough in the history of peptic ulcer pathology. Earlier, all peptic ulcers were considered to be due to erosion with the gastric, and that's why the name peptic ulcer comes in. In 2015, the peptic ulcers were H. pylori was identified by Barry Marshall and Robin Warren, for which they were given even the Nobel Award. And it was first identified in 1982, and the relationship of that were described in 2015. And by 2015, it was estimated that 50% of the world's population had H. pylori in their upper gastrointestinal tracts. Now, interesting issue is earlier, by the time it was invented in 82, and then it became popular, rather the peptic ulcer eradication program became popular. At that time, it was believed that peptic ulcer can be completely eradicated with the H. pylori, but of eradication of the H. pylori. But the incidence is now, as the data has accumulated, now it is known that more than 50% of the population in the world would have H. pylori organism in the GIT, but it may not result in the ulcer formation. Silent conditions could there. And the spread of this H. pylori infection throughout the globe also is quite almost widespread, and particularly in the eastern countries, including India, the incidence is supposed to be quite high. Now, H. pylori induced gastric ulcers are very characteristic, which can be even considered to be pre-malignant, and the chances of malignancy are quite high, and this is what's seen. And we usually grade the peptic ulcer, H. pylori induced peptic ulcer pathology into 6 categories. That's based upon the Kyoto classification. Either there could be a metaplasia, like the intestinal mucosa may be seen in case the stomach under the gastroscopy, or there could be a redness throughout, which is also named as map-like something like geographical map-like appearance, or the folds of the stomach could become enlarged, or there could be multiple nodular lesions or there could be diffuse redness, widespread redness, or there could be very prominent vessels seen. These are all the typical features of the H. pylori induced gastric ulcers. Now, H. pylori gastritis, the symptoms are usually very chronic symptoms. Intensity of pain is lesser. Relationship with the food is not very consistent. That also is considered as a variation of the peptic ulcer as such. It's supposed to be the risks of malignancy are quite high. The general line of the treatment now these days, it has become quite popular, that the peptic H. pylori eradication, and H. pylori eradication program will be usually either quadruple therapy where 4 drugs are used with the bismuth based therapy, or levofloxacin therapy, or there could be even the further progressive therapy which is done. But important is there are many patients who have become resistant to this kind of therapy, and they may not respond to this treatment, and prolonged use of proton pump inhibitors to suppress the symptoms has resulted in more frequent complications as such. And very significant observation is such patients who have H. pylori gastritis, they can be easily managed or maybe satisfactorily managed with Aragyavardhini, Agnitundi or Kamadga, depending upon their clinical presentation, and Kumaryasava or Bhunimbadikvata. When the patient has more pain as a symptom and reduced appetite, Agnitundi and Kumaryasava is prescribed. If the patient has a more burning sensation and maybe nausea-like symptoms, that pitta symptoms, Kamaduga and Bhunimbadikvata are prescribed, and with this the treatment is better. And as far as the incidence of H. pylori infection are concerned, usually it was considered that the patients with H. pylori would develop a gradual progressive pathology, and these along with that genetic factors, H. pylori infection can result in gastric cancer with the typical changes, like initially there could be chronic gastritis, and then it can result in intestinal metaplasia or dysplasia, and later it results in malignancy, or there could be even duodenal ulcers or gastric lymphoma also could be considered. So this is how it is believed, like attributed as such, and it results in a low level acid production continuously. Ultimately it results in the low level acid production, and there would be some alternative changes in the environment of the stomach. This is the real pathology, and there is actually a genetic tendency to have this H. pylori infection. These are all the advanced information which are present over there, and simple eradication program may not reverse these changes. Earlier, now in the 80s, whole peptic ulcers were considered to be a result of the acid secretion, and the acid secretions were assessed with the gastric function test, where the patient would be given a oat meal and the acid was collected at half an hourly intervals, and it was titrated. So the level of the acid could be free acid as well as the total acid could be put in a graph, and the peptic ulcer tendency were studied earlier. But and the usual pattern is the resting gastric acid level, free acid level would be less than total acid level would be less than 30 millimoles, whereas with the after oatmeal by around 1 to 1.5 hours in between, it reaches the peak of less than 50, and then again it comes back to the resting case by around 2.5 hours. This is a typical standard gastric function test which was done. But after the invention of H. pylori, this test has become almost obsolete. But and continuously the patients are administered proton pump inhibitors, and most of the times the proton pump inhibitors are the H2 receptor blockers, which are used as on the counter drugs. They will be resulting in a lower acid level, and that lower acid level itself could be a cause for the H. pylori, and these are the issues which are now coming up about the H. pylori. Earlier at one stage it was believed that once the H. pylori is completely removed, the chances of gastric pathology would be lesser, but the whole picture has been changed now due to these issues. Anyway, but still, I would still say that the better result can be achieved with the Aragyavardhini and Kumari Asavar Bhuni Barikvata Kamadika Agnizundi, etc. The another rare pathology, not a common, is Zollinger-Ellison syndrome, where the patient would have adenoma in the pancreas, and as a result of that, there could be excess of secretion of the acid, and this excess of the secretion of the acid will result in widespread pathologies, widespread erosion of the stomach mucosa as well as multiple ulcers. It's a rare phenomenon, and in such conditions, the primary pathology is in the pancreas, where there could be small adenoma, unidentified adenoma. That's one of the issues, but not frequent, and from the clinical point of view, they are rare. The only issue is a patient who is not responding to the therapy, usual therapies of the peptic ulcer, who continues to have multiple peptic ulcers. One possibility of Zollinger-Ellison syndrome has to be kept in mind, and if so, if it is proved to be so, the usual treatment of these proton pump inhibitors or so on might not help, and the treatment may have to be more energetic and more invasive. That's about one thing. Now, the next condition which we discussed related to the stomach would be the pyloric stenosis, or it's also now the current terminology used is a gastric outlet obstruction, where the outlet of the stomach, that the pyloric area, has become somewhat narrowed, and there is a stasis of the food in the stomach. The gastric emptying period would be prolonged, and that empty, because of that, the gastric phase of the acid secretion would be more. That results in the erosion of the stomach mucosa, and there would be even the changes in the stomach mucosa. Moreover, there could be vomiting. The more frequent vomiting, because of the food which stays in the stomach, would result in vomiting, and typically the vomiters would have lesser bile or no bile at all. Bile cannot flow back into the stomach because of the pyloric obstruction, and hence a bileless vomiting is characteristic feature. In due course of the time, that results in the dilatation of the stomach even, and because of this improper movement of the food from the stomach into the absorptive area, patient would have the malnourishment sequences. Endoscopy can confirm that. Barium meal also is one of the standard tool to make out the pyloric stenosis. The causes of pyloric stenosis could be many. The earlier it was more frequent due to the peptic ulcer resulting in cicatrization, but these days the peptic ulcer pathologies have become lesser, and the other next common cause is neoplastic changes. Malignant changes have maybe the other cause for the stenosis. So important is, once the patient has the pyloric stenosis, the condition has to be confirmed, the cause has to be confirmed, and the typical symptoms are weight loss, abdominal mass which could be palpable due to the dilated stomach, and the retrograde peristalsis also could be presented in many of these cases, and it's usually graded as when the patient is not able to take anything orally, it's graded as 0, and a patient who is able to take normal diet is graded as 3. In between, you have the other grades as such. And the causes could be congenital pyloric stenosis, duodenal ulcer pathology, tumors, or extragastric masses. And in these conditions, occasionally there could be spasm of the pyloric area, which could be temporary, which does not really require surgical intervention, could be due to any abdominal inflammatory pathology. Patient may have a vomiting which is due to the spasm of the pyloric pylorus as such. And once the primary pathology is cured, the patient that functions will be normal, which doesn't require really any intervention. Or the other causes could be systemic pathology like amyloidosis also can result in spasm, or vagotomy or mucosal resection surgeries also could result in the spasm, and in these conditions antispasmodic drugs could help. Whereas the other mechanical pathologies, surgical treatment would be necessary. And these I would consider them as a gulma because of the palpable features like, and the gulma features are Hannabhyo Antari Grandhi Sanchari Adiva Achalaha Vruktaha Chayapachayan Sah Gulma iti Kirtitaha. And the clinical symptoms are Udgara Bahulya, Purishabanda, that constipation, Trityakshamatva, intolerance to the food, and Antarvikujanani, Atopaha, Atmanam, the reverse peristalsis, retrograde peristalsis, Apakti Shakti, Asana Gulmase, Vadanti Jinnam, Aruchi, Krichra Binmutra Vatala, Antarvikujanam, Anahascha, Urdhva Atatum, a typical retrograde peristalsis is the typical sign. And the treatment would be, except in those conditions where the surgery would be absolutely necessary, where the patient may be in the 0, 1 or 2 grade, 0, 1 or 0 or 1 grade, medical treatment may not be possible. But if the patient in 2 or 3 grade, if we treat the patients with Agnitundi, Sudhashekara, Avipatikara or Hingvastagachurna, Jirakadrishta and Birachan with the Sukumara Garda Snehana, can help the patient have a significant clinical relief, though the condition may not be completely cured. That's one of the issues. The next part is about the tumors of the stomach. Tumors of the stomach could be again benign or malignant, and benign tumors could be again comparatively less frequent, but usually they are classified as mucosal or non-mucosal. Among the mucosal conditions, it's about the polyps which are seen quite frequently, and there could be polyps which could be considered as a neoplastic or non-neoplastic. That neoplastic or non-neoplastic differentiation can be made out only with the biopsy histopathology. So when you do the gastroscopy, you may see the polyps, and every polyp has to be subjected to the histopathology examination. And there could be again the patients present with the systemic polyposis syndromes, and the patients may not present with the systemic polyposis syndrome. The polyposis syndromes are malabsorption pathology. Because of the polyposis, there could be malabsorption pathologies, and hence any case of polyp has to be processed into this process of differential diagnosis, biopsy, and then confirm whether the patient has a polyposis syndrome or not. The polyposis syndrome conditions, they require more elaborate treatment, whereas non-polyposis syndrome conditions, many a times they could be just left out as such, and there could be no need of any intervention. Whereas neoplastic polyps, where there is a tendency of malignancy, they require more energetic treatment of excision. And non-mucosal tumors comparatively less frequent, and there again the diagnosis, the accurate diagnosis is quite a critical issue to decide about the course of the treatment. I will not go beyond that. Now, the typical appearance of these polyps under gastroscopy would be very characteristic. The hyperplastic polyp would be seen with the serrated adenoma, and juvenile hematomas could be seen with a smooth surface, and there could be tubular pedunculated polyps, which are more common of the neoplastic conditions. And Peutz-Jeghers hematoma could be presented as again a pedunculated, but the surface would be smooth. Villus adenoma, they are often benign conditions. Then pseudopolyps of different sorts could be seen. Adenocarcinoma, malignancy, would be seen as a mass with the irregular feature. And how we see exactly in the gastroscopy. So when you do the gastroscopy, these are quite important, like the ampullary adenomas, benign adenomas, and adenomatous polyposis. Then the typical hematomatous gastric polyp, which also could be seen quite frequently, and all these would be requiring a biopsy and then the confirmation of the treatment. Then the treatment protocol and the symptoms of these would be again to confirm benign or malignant. You will have to depend upon the typical clinical course as such, and the conditions could be have to be differentiated carefully, and then they need an elaborate approach. So that's all the point. Like, so a polyp cannot be neglected; it has to be studied, and then the treatment has to be planned as such. I would not suggest any general medical treatment. The only issue is elaborate study and follow up with the standard protocol is necessary. When it comes to the malignancy, which is again comparatively these days has become more prominent, more common as such, and the treatment outcome is extremely poor. And I would consider this as a annavahasrotas, where the patient would have continuous pain and more frequent vomiting, inability to assimilate the food as such. And there again, there could be adenocarcinomas, lymphomas, or stomal tumors, which are comparatively less frequent. The more frequent are the adenocarcinomas, which we see quite frequently. Incidence of them also is quite high in the eastern countries. In India also, the incidence is quite high as such. The typical incidence of malignancy, which has changed years a year as per the WHO this outcome. The symptoms, general symptoms of carcinoma of stomach are they usually peptic ulcers presenting with periodicity variation. Initially peptic ulcer, when it presents, there will be a relationship with the food, and gradually as the patient continues to progress, if the relationship with the food is altered, the patient may continue to have the pain continuously. In such conditions, it's a high possibility of malignancy. Symptoms of indigestion, nausea, vomiting, difficulty in swallowing, a fullness after the food, loss of appetite, melena or anemia, hematemesis, these are the important signs. Weight loss is one of the most important clinical signs, which we call as danger sign in patients of gastric pathology. If the stomach becomes palpable or dilated stomach is presented with succussion splash test, if the lymph nodes are enlarged in the neck, supraclavicular lymph nodes, or there could be anterior axillary nodes also could be seen, then that could be a possibility of malignancy many times. Then the complications would be, it can result in peritoneal or pleural effusions. The gastric outlet could be completely obstructed, either at the pyloric end or maybe the proximal end. Bleeding in the stomach from the esophageal varices also can occur after surgery. Intrahepatic jaundice or extrahepatic jaundice could occur. Prognosis is now in the current treatment protocols. Stage 1A, early stages, the 5-year survival period is around 71%, whereas if it has advanced like stage 4, then the survival period comes to 4%, and that's why early diagnosis is important. That's about the tumor pathology. As far as the treatment protocol is concerned, if a patient is diagnosed as CS stomach, I would not start treatment by myself. Instead, I would be referring the patient to an oncologist. In the current protocol of the treatment definitely produces some significant outcome. But if the patient has gone to that stage where nothing can be done, or the prognosis is extremely poor, I may treat the patient after explaining the prognosis to the patient clearly, and the treatment idea, the aim of the treatment is only to improve the quality of life, improve the appetite, and usual treatment would be Arogyarjini Kumarya Sava and the same medicines which we have discussed as such, which can reduce the symptom of pain but may not produce a change in the course of the disease as such. So anyway, that's about one set of the diseases. Another set of the diseases related to the stomach is motility disorders, where the movement of the food in the stomach is abnormal and hence the symptoms would occur. And of course, these disorders also are linked to the same peptic pathologies, which also can result in abnormality of the secretions and the digestive functions. But from the treatment point of view and the clinical symptom point of view, these are important. Among them, the most important is the gastroesophageal reflux disorder, GERD, which is becoming now more common, more frequent now. The typical presentation or pathology would be in the normal conditions, the contents of the stomach would not move to the esophagus unless there is an act of vomiting. In the routine conditions, the esophagogastric junction would be competent and it will prevent the contents from the stomach to flow back into the esophagus normally. But if there is an incompetence of this mechanism, or the pressure in the stomach is increased and pressure in the esophagus becomes lesser, there could be a flow back into the esophagus. Esophagus normally is not conditioned to have the acidic content, the acidic pH is not normal environment there. And if there is a reflux there, it can produce erosion and inflammation of the esophageal mucosa, and this kind of symptoms tend to occur quite frequently. And these days the incidence of these symptoms are more frequent due to two reasons. One, the reduced physical activity results in a impairment of the muscle tone, and that itself could be a cause for the reflexity. Obesity is other cause for that reflux, or it could be even due to the food, more frequent consumption of the food, where the stomach never becomes empty. That also can result in the reflux disorders. Quality of the food also can be a cause for the reflux disorder. The typical clinical symptom will be that the patient would have a burning sensation in the chest, occasionally nausea, and more frequent after the consumption of food. If the patient lies down, the symptoms will be more. In the erect posture, the symptoms will be lesser. And that is the typical feature of the Pitta Vata varieties, either Udana, Pitta Vata Udana, or it could be Samana, Pitta Vata Samana, where the same symptoms could be characteristically present over there. And the typical treatment in such conditions also would be same, like the same Shuddhashekara, Kamaduga and Godanti Avipattikara, the usual treatment of Deepana as such. The one of the important advice to the patient would be advise the patient to have a little lesser quantity of the food, and the frequency of the food intake has to be minimized, reduced as such, and regularity of the food intake also is one of the important issues. One very useful advice to the patient would be not to lie down within 2 hours after the food. Say after consumption of the food, at least for next 2 hours, patient should be in the erect posture, and sleeping or lying down at that time can increase the chances of acid reflux disorder. These days, these reflux disorders are considered to be causes for the later complications of stenosis of the esophagus, strictures, and so on, and these can be again quite troublesome as such. Then the next condition related to the stomach would be, again it's a sort of symptomatic pathology which we consider as a chardi. Very frequently seen, the patients will be presenting with vomiting. Now vomiting or chardi could be a symptom of large number of disorders of the systemic disorder, as well as occasionally it has to be considered as a chardi vyadhi. In the current surgical terminology, the vomiting is not considered as an individual diagnosis, but very recently ICD has added that also as a condition where the causes of these are not known. From Ayurvedic point of view, when the vomiting occurs as a result of other disorders, it could be considered as the lakshana. But when it is produced due to psychological conditions, bhivatsa alojanadi stress or looking at something which is not acceptable, the chardi occurs, the vomiting occurs, that is considered as chardi. Or it also could be considered due to the type of the food. Ati dravehi, ati snigdehi, ahradyehi, lavanehi api, akale chati matreshya tata asapneshya bhojanehi. If you consume a food which is not suitable in both physical form as well as its presentation, or even the timing of the food is not proper, then it is considered, when it produces vomiting, that's also considered as chardi. और श्रमात् भयात् तथा उद्वेगात् अजीर्णात् कृमिदोषधः नार्याश्च आपन्नसत्त्वायाः तथा अतिद्रुतम् अश्नतः बीभत्सैः हेतुभिश्च अन्यैः द्रुतम् उत्प्रेषितो बलात् छादयन्नाननं वेगैः अर्दयेत् अङ्गभञ्जनैः. These are the other causes: excess of stress, or these worms in the intestines, or pregnancy, which also can produce vomiting. These are considered as a chardi vyadhi. In other conditions, it could be the symptoms of other conditions. From the current point of view, we assess the causes of vomiting under these heads, like the either cerebral cortex induced pathology, or vomiting, where anxiety, raised intracranial pressure, etc., can be a cause for that. Or it could be due to stasis in the stomach, abnormality of the stomach, where the patient may have the gastrointestinal tract infections or GH disorders, liver pathology, etc. Drugs or hypercalcemia also can produce vomiting, which also is related to both stomach as well as the central pathology. Then vestibular neuritis also can produce the vomiting as such, and hence a condition of vomiting has to be assessed from the clinical point of view. The causes of that have to be assessed and the treatment has to be followed, though the vomiting is controlled by the vomiting center. The common causes are alcoholism, drugs like infective pathologies like infections, etc., and metabolic pathologies, diabetic ketoacidosis, or so on, psychogenic conditions, CNS disorders, gastrointestinal tract pathologies, uremia, and acute abdomen conditions also can produce the vomiting, and these have to be differentiated, and the planning of the management will be accordingly. The common type of the antiemetic drugs which are used now symptomatically in the present time are either antihistamines or dopamine 2 receptor blockers, or receptor antagonists, or serotonin blockers, or neurokinin blockers are commonly used. But as far as Ayurvedic point of view are concerned, when I treat the patients, I would be preparing, like if it is due to the food poisoning, Agnisthani Anandaviravi is the usual prescription. Gastritis like conditions, Sudshekara Kamaduga. Peptic ulcer pathology, Sudshekara Kamaduga, Gosanji Hepatical, etc. And the treatment has to be prolonged. One manifestation, Primikudharas and Agnipindi. Hepatitis, Mrityunjaya Arogyotini Kumari Asava. Vestibular pathology is Kamaduga and Smithsagarasa. If it is neurosis, Smithsagara acid. Mayurapichavasma is one of the symptomatic remedy which can reduce the symptoms as such. Now that's about one of the conditions. Another common presentation which we see in the clinical presentation is the abdominal pain condition. Abdominal pain could be of different categories, and the causes also have to be assessed. But there is still many times the exact causes of the abdominal pain is very difficult to make out, and many times even after all the investigations you may not be able to make out that abdominal causes. The pain causes cannot be made out, and from the ICD coding point of view, the coding is now done as abdominal patients presenting with abdominal and pelvic pain. The coding is R10, and then you have the subcategories depending upon the causes. Pelvic and perineal pain is R10.2. Other abdominal pain conditions are 10.8. Patient with the abdominal pain and tenderness 10.8.1. Rebound tenderness, which is suggestive of inflammatory pathology, is 10.82. So the whole approach to the diagnosis is now altered. Before you go for the investigations, you can make out these conditions as such. This shows the importance of a basic clinical assessment. When a patient presents with the pain in the abdomen, you will have to get the history, like the factors which trigger the pain, factors which aggravate the pain, and the factors, the clinical examination like location of the pain, duration of the pain, whether there is a tenderness accompanied with that or not, or the other symptoms that are accompanied with the pain. They have to be detailed, history has to be taken, and then the diagnosis has to be made out. Now, when the exact diagnosis is made out, the treatment approach would be totally based upon the exact causes. Now, when you have that condition where the exact diagnosis cannot be made out, and if the patient is presented with the pain, I would be considering them as the Shula, and the Shula could be of different categories. When the pain is more in the upper abdomen conditions, it's usually the pain produced due to the same Vatamutra Purishara, Nigraha, Dhatibhojanat, Ajirna, Adhyashana, Ayasa, Viruddha, Arnopasemanat, Paniyapanat, Kshut Kale, Virudanam Semanat, Pista Arna Shushka Mamsanam Puyaka Jevaja, Evam Vidhanam Dribyanam Maneshan Chapasevanat, Vayu Prokopita Koste Shulam Sanjane Brisham, which is due to the pain produced due to the abnormal type of the food or improper digestion, which is usually transient, temporary, short duration onset where the patient can attribute it to a cause of the food as such. That's the typical of the Shula. And there again, if the patient has a Vataja Shula, like empty stomach, pain is more in the empty stomach, and निराहारस्य तीव्रं शूलदे प्रसुद्धगात्र भवति कृच्छ्रेण उच्छ्वसिति च वातरं उदपुरुषाणि कृच्छ्रेण कृतेन रः. In such conditions, my prescription as a symptomatic treatment would be annavahasrotas jirakadirishta. But in all these conditions, a rigorous attempt has to be made to make out the exact causes, and when there is exact causes identified, the treatment protocol would vary. But before you are able to make out the diagnosis for the symptomatic relief, I would be preferring these drugs like. Whereas in Kapha Shula, where the patient would have a heaviness in the abdomen, distension of the abdomen, and reduce the appetite, I would be prescribing Agnitundi, Bhunimbati, Kvata, etc. The patients with the inflammatory pathology, burning sensation, usually, and fever-like symptoms, usually are produced due to inflammatory pathology of the abdomen, like pancreatitis or maybe appendicitis or so on. In such conditions, the treatment has to be exactly based upon the real causes. So, I may not suggest any specific symptomatic treatment for that condition. If the pain is severe, the analgesics may have to be given in such conditions, and a detailed treatment protocol is to be necessary. Then and these could be considered as either gulma or udara or antarvidriti, and the treatment has to be along with that lines, appendicitis or inflammatory pathology of the abdomen. The treatment has to be on the line of gulma or antarvidriti or udara, and the clinical, I would make the diagnosis of these conditions exactly on that issue. As far as a bit more of the detail, we will continue in the next session. We will stop at this time because of certain other commitments. If there are any questions, I will try to answer, and then we will continue in the next session. Right.